Hello viewers, it's Emmanuel here, and today we'll be talking about heparin and warfarin. We'll be learning about some differences between these two medications, which has been mostly a challenge in our MCQs, and also students find it mostly difficult to differentiate between the two drugs. So today we will be learning some 6 key differences between warfarin and heparin. Okay, so to begin with, we'll talk about the route. So with the route of administration, we have heparin that is mostly given IV or subcutaneous. So we mostly administer it subcut, just like we administer insulin, and mostly can also be given through infusion, that is mostly 80 units per kilogram. And warfarin is also given oral, so mostly because it's being given after discharge for continual therapy. Now let's come to the onset. So with the onset, with heparin is almost immediate. So if you have any acute coagulopathies like pulmonary embolism or DVT, which is in the acute phase, we need emergent interventions. We have to go for heparin because it works almost immediate. But warfarin, on the other hand, has a delayed onset, which means that it may take about 3 to 5 days before the actual work begins. So we mostly give heparin when we are in acute, or we need it for an acute purpose. With the mechanism, heparin boosts an existing protein in our body called antithrombin 3, which blocks thrombin, that is through factor XA. And warfarin, on the other side, is a vitamin K antagonist. That is the other name that they call it mostly. It do this because it blocks all the vitamin K dependent protein factors, in which you can use this to remember 1972. So this means that factor 2, factor 7, factor 9, and then factor 10. Let's talk about some of the lab monitoring that we do in warfarin and heparin therapy. So with heparin, mostly the labs that we use in monitoring is the aPTT, which is the activated partial thromboplastin time, that measures the rate at which prothrombin converts into thrombin. So I think our last video that we did on black clot formation, we talk about how prothrombin converts into thrombin, and then fibrinogen into fibrin. So just checks the rate at which prothrombin converts into thrombin, which has a therapeutic range of 60 to 90 seconds. It's very important when we use these lab values to check for the levels of heparin to be given, whether we reduce it or we increase it, whether there is an overdose. Then we know the appropriate interventions to do. Warfarin, on the other side, we use the PT-INR, which is the prothrombin time or the international normalized ratio, which also have a therapeutic range of 2 to 3 seconds. And we use that also to check the levels of warfarin that are supposed to be given. So whether there is an overdose, we can know it. That is when it's more than normal, there is an overdose. And vitamin K is that of the antidotes that they use mostly in warfarin therapy. So we're talking about the both antidotes. So with the antidote that we use for heparin, we have potassium sulfate, and then with the antidote we use for warfarin is vitamin K. So after we measure the lab values, which is either the aPTT levels, which is for heparin, and then the PT-INR levels, which is for warfarin, we check whether they are within the therapeutic range. If it is more than the therapeutic range, it means that there is high tendency of bleeding and we need an antidote to prevent complications. Okay, now let's talk about pregnancy. So in pregnant women, mostly it's safe to give heparin, but warfarin is highly teratogenic and can lead to fetal abnormalities. Okay, so there is another thing that we talk about, which is the bridging method. So there is some method that mostly we use by doctors or healthcare providers. We give both warfarin and then heparin at the same time. It's called the bridging method, and in this method we give both the two medications at the same time for around 5 days, because heparin have an immediate onset. We start it, that is at the regular time, and then warfarin is also started at the regular time. So we give it for 5 days, and we check the INR levels. If the INR levels is within the therapeutic range, which is 2 to 3, then we stop the heparin and continue with the warfarin. So mostly in the nursing management of patients taking these medications, it's very important to educate them. Let's say warfarin. So with warfarin, mostly we have to educate them to continue eating their green leafy vegetables like spinach or kale. It's very important. They don't have to eat it that much. They have to eat it in moderate, alongside taking the medication, which is also a source of vitamin K. So another thing we need to educate our clients on this medication is to prevent contact or any sort of contact spores, and then also to use electric razors only, and also to use a soft brittle toothbrush in brushing their teeth, which we want to prevent any sort of bleeding from any part of the body, which can be a major complication. There's another complication that we have mostly, that is heparin therapy. So it is called heparin induced thrombocytopenia, in which the body's platelet count reduce mostly by 50%, and it's very good when we monitor the aPTT levels to check whether we need to reduce or increase the heparin, the amount of heparin that we are to give to our patients. Thank you very much for watching this video. If you found this very helpful, give us a like and make sure you subscribe to our channels. Bye.